Welcome back to the Nurses Study Partner. This is GORD, also written GERD, Part 2, Complications, Barrett's, Surgery, and Special Cases in 10 in-depth scenarios. We'll cover erosive esophagitis, peptic strictures, Barrett's esophagus and its cancer risk, refractory reflux, anti-reflux surgery, hiatus hernia, and reflux in pregnancy, infancy, and long-term PPI use. Read each case, weigh all four options, pause to choose, then check your reasoning. Let's begin. Question 1. A patient with years of poorly controlled reflux has an upper endoscopy showing several breaks in the lining of the lower esophagus, graded on the Los Angeles classification. What does this finding represent and how is it treated? Option A. Normal mucosa. No treatment of any kind is needed. Option B. Erosive esophagitis. Heal it with a course of PPI. Option C. Definite cancer, so start chemotherapy immediately. Option D. A stomach ulcer that has nothing to do with reflux. Pause here and choose your answer. The answer is B. Erosive esophagitis, healed with a course of PPI. Visible mucosal breaks in the lower esophagus are erosive esophagitis, a complication of GORD, graded A to D on the Los Angeles classification by the extent of the breaks. Treatment is a course of a proton pump inhibitor, usually 8 weeks, which heals 80 to 90% of cases, then review. It is neither normal, automatically cancer, nor an unrelated stomach ulcer. Question 2. After many years of reflux, a patient reports food sticking in the lower chest, first with solids like bread and meat, now steadily worsening. Endoscopy shows a smooth, benign narrowing of the lower esophagus. What has developed and what is the management? Option A. An infection. Treat it with a week of oral antibiotics. Option B. A psychological problem. No physical cause is present. Option C. Simple heartburn. Increase antacids and reassure him. Option D. A peptic stricture. Endoscopic dilatation plus a PPI. Pause here and choose your answer. The answer is D. A peptic stricture managed with endoscopic dilatation plus a PPI. Progressive dysphagia to solids with a smooth benign narrowing after chronic reflux is a peptic or benign esophageal stricture from fibrosis and scarring caused by long-standing acid injury. Management is endoscopic dilatation plus a PPI to control reflux and prevent recurrence, and any stricture also needs biopsy to exclude malignancy. It is not an infection, psychological, or simple heartburn. Question 3. A patient with long-standing GORD has an endoscopy and biopsy showing that the normal squamous lining of the lower esophagus has changed into columnar intestinal type epithelium. What is this change and why does it matter? Option A. A harmless color change with no clinical importance. Option B. An acute infection that antibiotics will quickly cure. Option C. Barrett's esophagus, a pre-malignant metaplasia. Option D. Simple scar tissue that will turn back to normal alone. Pause here and choose your answer. The answer is C. Barrett's esophagus, a pre-malignant metaplasia. Chronic acid reflux can cause the normal squamous lining to change into columnar intestinal type epithelium, Barrett's esophagus, a form of metaplasia. It matters because it is pre-malignant, carrying a small but real risk of progressing through dysplasia to esophageal adenocarcinoma, so patients enter endoscopic surveillance. It is not harmless, an infection, or simple reversible scar tissue. Question 4. A patient with known Barrett's esophagus asks why he needs regular endoscopies when he feels well and his heartburn is controlled. Which explanation is most accurate? Option A. Surveillance can catch dysplasia or cancer early when curable. Option B. The scopes are only done to check his medication doses. Option C. Barrett's never changes, so the tests are purely routine. Option D. Feeling well means the Barrett's has completely resolved. Pause here and choose your answer. The answer is A. Surveillance can catch dysplasia or cancer early when it is curable. Barrett's esophagus can slowly progress to esophageal adenocarcinoma via dysplasia, and this can happen even when symptoms are controlled. Endoscopic surveillance with biopsies aims to detect dysplasia or early cancer at a curable stage, allowing early treatment. The scopes are not just for dosing. Barrett's can change, and feeling well does not mean it has resolved. Question 5. A patient still has troublesome reflux despite a standard dose PPI. Before escalating treatment, the team wants to work out why the PPI is not helping. Which is the most appropriate next step? Option A. Immediately book major anti-reflux surgery for him. Option B. Check adherence and timing, then confirm with pH impedance. Option C. Stop all treatment and tell him nothing more can help. Option D. Add a strong opioid to mask the ongoing symptoms. Pause here and choose your answer. The answer is B. Check adherence and timing, then confirm with pH impedance testing. For refractory GORD, first check the basics, adherence and correct timing, since PPIs work best 30 to 60 minutes before food, and optimize the dose. If symptoms persist, confirm the diagnosis with esophageal pH impedance monitoring with manometry and consider other causes such as functional heartburn or eosinophilic esophagitis. Jumping straight to surgery, stopping care, or adding an opioid would be wrong. Question 6. A younger patient with confirmed severe GORD and troublesome volume regurgitation has responded only partly to maximal medical therapy and does not want lifelong PPIs. Which operation and principle apply? Option A. Total removal of the stomach to stop acid production. Option B. Cutting the esophagus open to widen it permanently. Option C. Simply removing the gallbladder to reduce the reflux. Option D. Nissen fundoplication. Wrap the fundus around the LOS. Pause here and choose your answer. The answer is D. Nissen fundoplication. Wrapping the fundus around the lower esophageal sphincter. The standard anti-reflux operation is a fundoplication, usually laparoscopic, in which the gastric fundus is wrapped around the lower esophagus to reinforce the sphincter and reduce reflux. It's considered for confirmed severe or refractory GORD, troublesome regurgitation, or a patient's preference to avoid lifelong PPIs. It is not a gastrectomy, an esophageal incision, or a gallbladder removal. Question 7. A patient's investigations reveal a hiatus hernia. How do the two main types differ and relate to reflux? Option A. Sliding is commonest and linked to reflux, rolling less so. Option B. Rolling hernias are the only type that ever cause reflux. Option C. Hiatus hernia has no connection to reflux whatsoever. Option D. Both types always require emergency surgery at once. Pause here and choose your answer. The answer is A. Sliding is the commonest and is linked to reflux, while rolling is less so. In a sliding hiatus hernia, the commonest type, the gastroesophageal junction slides up through the diaphragm, weakening the sphincter and promoting reflux. A roll-in or paraesophageal hernia has the junction in place, but part of the stomach herniates alongside the esophagus. It causes less reflux but risks strangulation. Not every hernia needs emergency surgery, and it is clearly reflux related. Question 8. A woman who is 28 weeks pregnant has troublesome heartburn, especially at night, and lifestyle changes alone have not been enough. Which is the most appropriate first line management? Option A. Tell her nothing can be done safely until after delivery. Option B. Start a strong opioid to settle the heartburn quickly. Option C. Lifestyle advice plus antacids or alginates first line. Option D. Advise her to lie flat after meals to ease the symptoms. Pause here and choose your answer. The answer is C. Lifestyle advice plus antacids or alginates first line. GORD is very common in pregnancy, from hormonal relaxation of the sphincter plus the enlarging uterus. First line management is lifestyle measures, small frequent meals, not eating late, raising the bed head, plus antacids or alginates, which are considered safe. If needed, acid suppression with an H2 blocker or PPI can be used under guidance. Doing nothing, an opioid, or lying flat would be wrong. Question 9. Parents bring their thriving 3-month-old who brings up small amounts of milk after feeds. He is gaining weight well, feeds happily, and has no distress, blood, or breathing problems. Which is the most appropriate response? Option A. Reassure. Physiological reflux usually settles. Safety net. Option B. This is a surgical emergency requiring an urgent operation. Option C. Start him on lifelong high-dose acid-suppressing drugs. Option D. Stop all milk feeds immediately to rest the stomach. Pause here and choose your answer. The answer is A. Reassure the parents that this is physiological reflux that usually settles and safety net. Effortless positing in a thriving happy baby is physiological gastroesophageal reflux, which is very common and usually resolves by around 12 months as the sphincter matures. Management is reassurance and advice on feeding position and smaller, more frequent feeds with a safety net for red flags, poor weight gain, distress, blood, breathing problems, or projectile vomiting, which would need review. Surgery, lifelong drugs, or stopping feeds are all wrong. Question 10. A patient has been on a PPI for several years and asks whether it is safe to keep taking it indefinitely, having heard it may cause problems. Which response best reflects safe practice? Option A. PPIs are totally risk-free. Stay on the highest dose. Option B. PPIs are so dangerous they must be stopped abruptly today. Option C. Use the lowest effective dose. Review and step down. Option D. The dose should be doubled every year automatically. Pause here and choose your answer. The answer is C. Use the lowest effective dose, review, and step down. PPIs are effective and generally safe, but long-term use carries small potential risks: low magnesium, low vitamin B12, C. difficile, and other enteric infections, and possibly fractures. Good practice is to use the lowest effective dose, review periodically, and step down or deprescribe where possible. Not to stay on the highest dose, stop abruptly for no reason, or keep escalating. Let's recap GORD Part 2. Erosive esophagitis is graded A to D on the LA classification and heals with a PPI. Chronic reflux can cause a peptic stricture, giving dysphagia, treated by dilatation plus a PPI. Barrett's esophagus is metaplasia, the squamous lining becoming columnar, and is pre-malignant, so it enters surveillance to catch cancer early. For refractory reflux, check adherence and timing, then confirm with pH impedance testing. Nissen fundoplication wraps the fundus to reinforce the sphincter. Sliding hiatus hernia is the common reflux-linked type. Rolling is paraesophageal. In pregnancy, use lifestyle measures plus antacids or alginates first. Infant positing in a thriving baby just needs reassurance and a safety net. And with long-term PPIs, use the lowest effective dose, review, and step down. Keep going and remember, we don't pass alone, we pass together.